welcome to the first episode of Ask Me Anything, whereby I'm going to answer as best as I can the questions that you have submitted on the newsletter and also on social media. Lots of the questions had similar characteristics, so I'm just going to go through quite a few of the questions, try and give some high-level answers to the questions as best I can. A couple of things before we start. Firstly, basically any information we give here are answering general questions with general information, so we can't look at a specific medical question that a specific person has and give them specific medical advice. You should never take advice from someone you are listening to on the internet. That information that we give you here should be used in consultation with your own physician. So that's really important to clarify. The second thing is somewhat actually linked to the first question, insofar as that lots of people have submitted questions around a particular topic or idea or having me reflect on a certain medical issue. But some people have submitted entire medical histories with very specific medical information. I can't actually answer that because that is actually the practice of medicine, and that is not what we should be doing on online forums like this. This is for general information to give you an idea around the concepts that I think about on a daily basis and how I think about those, and to see how you can use that information to integrate into your own healthcare with your own doctors. So with that in mind, we'll jump into some of the questions. We'll get through as many as we can, and I hope you find this useful. If it is, we can do more of them. So one of the questions here that comes up is, does it make sense to do a short course of statins, say 3 months, combined with dietary enhancements, and then go off the statins, and if there has been a good reduction in LDL? I would say if you're going to make any change ever, always look at making one change at a time. So you don't want to make dietary changes and go on a statin therapy and then actually see where you land if you're trying to determine which is giving you the best benefit, because you won't be able to tell the difference. In general, we know that statin therapy or any medical therapy combined or used in isolation can give you a reduction in LDL cholesterol of anywhere between 20 to over 85%. So that can be a very potent tool. Dietary changes are much more kind of blunt in their implementation. Average changes in LDL cholesterol can be anywhere around 15%. Some people get really no change, and some people get a very big change. So I wouldn't recommend changing two variables and then actually trying to figure out which one caused it. I would change one variable at a time. So it's not unreasonable to say, listen, I'm going to make some dietary changes, see how that impacts my LDL cholesterol. Is that change sufficient? And if not, do I need to close the gap that exists between my optimal cholesterol with a medication? So next question is, what is the best way to get a current heart health check? Full medical, calcification, other tests from a 51-year-old male. You need to be very precise what you mean by a health check. So health can mean lots of different things to different people. So I would go at this in generally a much more precise fashion. When I say health check, I'm referring to cardiovascular disease, but also the main things that actually drive risk for lots of other conditions, which are the primary drivers of risk later in life, which are cardiovascular disease, cancers, and dementias. Now, if you get the factors for heart disease right, you generally get the ones for those specific conditions right also, but also there are obviously very specific screening or medical testing things that you can do for, say, cancers and also dementias, for example. So when you say a health check, I would try and get more precise in your language in terms of how to actually go about doing that testing. Let's see here, a question around blood pressure. 60-year-old male with a blood pressure of 130-ish on 80-ish. Is your advice to keep it under 120, and does that target change as we age? So I have a phrase around this, that okay blood pressure is not okay. In general, blood pressures consistently in the mid-130s compared to the 120s, the low 120s, are associated with about a 25% increased risk of major heart events. So in general, for the absolute majority of people, you're aiming for blood pressures in the low 120s. In terms of age, this applies for most people except for those who are maybe very elderly or frail, and in that category of individuals, we need to be a little bit more cautious around aiming for such strict targets. But broadly, for most people, you're aiming for the low 120s or below to achieve optimal reductions in risk. And that is either by way of lifestyle, ideally, or with medications as needed. Let me see here. How do you respond to the claim that statin takers overall don't live any longer than non-takers? So this is really a question, more precisely, does statin therapy or lipid-lowering therapy change all-cause mortality? Now, the answer is yes. If you look at the meta-analysis of these studies, there is an all-cause mortality advantage. That is the reduction in the chance of dying from anything. However, if you're looking at all-cause mortality as an outcome in a study, you have to do the study for a very long period of time. And invariably, when we look at drug studies, they are often done between 3 and 5 years. Historically, cholesterol-lowering medications trials were done over about 5 years. Now they're done in as little as 2.5 years. So the likelihood of being able to demonstrate an all-cause mortality benefit is much less. And that is why we often see composite endpoints used in trials now. So that's a combination of multiple endpoints, things like heart attacks, cardiovascular death, all-cause death, say stenting, for example, and they're bundled together to account for one outcome, and that's what's called a MACE event, or major adverse cardiovascular event. We rarely do testing for all-cause mortality endpoints. So the answer, I would say, based on the totality of information is yes, there is information to that, but B, the reality is no trial has ever been specifically done looking for that particular outcome. Could you comment on the relevance of HbA1c parameters? So basically HbA1c is a rolling 6-week average of your glucose. So the higher your average glucose over a period of time, the more likely you have suboptimal glucose control and whether or not you are insulin resistant or moving towards prediabetes. So we know that above certain thresholds in Europe, generally it's an HbA1c above 42 indicates pre-diabetes, and below that is said to be normal. But what's interesting is that if you actually look at the normal range of HbA1c, you can draw a fairly clear relationship across the normal range that the higher the HbA1c, the worse the outcomes, particularly as it relates to heart disease. So HbA1c is a really good, I think, lagging indicator for average glucose control over time. It can be distorted by certain factors related to hemoglobin, but in general, it's a really good one to track the change over time. Now, clearly, if it's in the pre-diabetic range or the diabetic range, that indicates significant insulin resistance, but tracking it over time as it changes through the normal range is actually a really useful thing to do. Let's see here. There's a question, I think, around changes in statin therapy on a patient who has a cardiac CT. So one of the things that people often get frustrated with is that they are started on, say, a cholesterol-lowering medication, such as a statin, for example, when they have a cardiac CT and it is identified that their cholesterol is high and they have documented coronary disease. What frustrates people often is that they come back after a period of time and the cholesterol-lowering medication is increased or a second is added, and they get frustrated to think that maybe that they're doing something wrong, and invariably that's not the case. What is happening here is that the cardiologist or the physician is aiming for a specific target. So European guidelines, we would aim for an LDL of less than 1.4 in someone with documented coronary artery disease, and that is sometimes difficult to get to and will require titrations of medications or combinations of medications together, and sometimes the patient can be frustrated that that the first dose isn't getting them to target. My take on this is that, in the words of Charles Bukowski, if you're going to go all the way. And so basically, if you're going to take the fixed downside risk of going on any medication for that matter, you want to make sure that you're extracting the maximum value. So if you're going to go on the therapy, it is generally best, in my view, to titrate it till you get to target. So there's no such thing as high dose and low dose, in my view. There really is only the dose of the medication that is necessary to get you to target. Thoughts on the Esselstyn diet for severe coronary artery disease? Is the extreme restriction able to reverse coronary disease, and any recommendation on diet for severe coronary artery disease? So the Esselstyn diet was a fairly restrictive diet studied several years ago and looked at a cohort of individuals basically on angiography, and quite a few of them actually had reversal of coronary artery disease. It was documented on the basis of a flow analysis on their angiogram, which is not the most precise thing in the world, but we know in general from follow-up studies that even kind of what we would call quote-unquote healthy diets along a Mediterranean style have been shown to change the composition of plaque, haven't really been definitively shown to reverse or reduce non-calcified plaque. So what I would say is my primary goal for individuals is diet is primarily a tool for modifying your degree of visceral fat, and that is largely a function of calorie control. It is also about maintaining adequate fiber and protein for muscle mass and muscle synthesis. So I don't get too bothered otherwise about the constituents, but we have to modify it for each individual. Let me see here. I read back on Dementia by Patrick Halford that homocysteine reading is a greater indicator of cardiovascular health than your cholesterol readings. True or false? So this is a really interesting one. People are incentive-based creatures. Patrick Halford, whom I don't really know anything about, but I did do a quick search, and the first thing that I saw was that if you wanted to buy your best range of supplements, you could click on his link. So it's interesting here is, number one, homocysteine has some loose relationships to inflammation and cardiovascular disease. The strength of those relationships have gone in and out of favor, but interestingly, to correct high homocysteine levels typically requires high doses of B-complex vitamins. So this is where it gets interesting. If you're pitching excess homocysteine as the primary driver of cardiovascular risk, which it isn't, you're then kind of saying, listen, I have the solution. And so this is where you need to be careful about integrating these pieces of information. As I said, I don't know much about his whole approach. Maybe he has a very comprehensive, similar approach to mine, but in general, the literature is pretty clear that homocysteine levels are not going to be better long-term predictors of cardiovascular health. Is there an upper age limit where cholesterol testing and treating with the statin is of little benefit? So this is a very interesting question and something we often very much struggle with, but we actually have data from those over age 75 years of age, that assessing cardiovascular risk and using lipid-lowering therapies reduces risk. Now, that has to be in the context of, say, if someone is 77 years of age and has multiple comorbidities and is very frail and bedbound, clearly we're not going to follow such approach. But for individuals who are generally going to fit and healthy in those age ranges, who maybe have a degree of risk that is worthwhile treating, it's certainly not a barrier for me, that particular age category. Can calcification be reversed? So this is a really good question and something that I will get asked after showing someone their cardiac CT when they have documented coronary disease and an elevated CT calcium score. So calcification is a proxy marker for plaque, but people will immediately say, listen, can I get rid of it? And the answer in first pass is no. Calcification is the repair process that happens in your arteries, and fundamentally that will stay there indefinitely. But what you can regress to a degree is the amount of non-calcified plaque, and you can change the composition, generally best illustrated with a very aggressive lipid-lowering therapy. So calcification, no. What are the probabilities that taking statins is going to cause diabetes? So this is often a quite controversial topic, and there is a very clear relationship with lipid-lowering therapy and the onset of a degree of insulin resistance and sometimes diabetes. However, you need to look at the studies that actually show this, and it ranges from an 11% risk increase to 20% risk increase, depending on the study that you actually look at. But the majority of the patients who went on to develop diabetes in any of these studies pretty much were diabetic at the start of the study and often had just a very small bump in their HbA1c. So it's not that you actually take somebody who's entirely insulin sensitive and then just make them insulin resistant by going on statin therapy. Additionally, we will often, we will always be tracking their glycemic metrics over time. And if we think, all things unchanged, that the introduction of the medication has actually caused a bump that is concerning, we can switch to a different therapy or try a different approach. So the risk is real, but it is generally manifesting diabetes in people who are already pre-diabetic. Let's see here. So this is a question really around someone who is on blood pressure and cholesterol-lowering medications, weighs 105 kilograms and struggling to get their weight down and really wants to lower weight. Would you advise the option of a weight loss drug? So weight loss medications have become incredibly controversial, and I think this is not good. Effectively, they are tools. They're simply tools to get you to an endpoint. We know that in people at high risk, they reduce cardiovascular events by about 20%. But what I would say is that the primary risk reduction is going to be achieved primarily through not simply weight loss, but improvements in metabolic health. And this has been shown that the benefit and reduction in cardiovascular risk is directly linked to the reduction in HbA1c, or your metabolic health, rather than just your weight. Because as I often say, I'm not interested in weight and I'm not concerned by it. What I'm concerned by is excess weight in the wrong place causing a metabolic consequence. And that is often excess visceral fat. So what you want to do is the function of these medications is to improve metabolic health, not just reduce weight. So these are medications that I'm using much more commonly with my patients. Just like any medication, they have the potential for downsides that we have to monitor. Currently, they come at a fairly hefty price point. So this is a big challenge for a lot of individuals. So they're not broadly available, but we have seen this story play out over and over again. And it won't be long before we see these medications freely available, just like a lot of other medications that are used, and the excess price point will be taken away. Let's see here. In your opinion, how credible is the concern that aggressive LDL lowering, say long-term statin therapy, can increase dementia risk, especially in certain genetic subgroups? And how do you balance cardiovascular benefit versus potential cognitive risk? So it's important to understand that science is the process of using all of the information that we gather together and understanding that the majority of it ideally will point in one direction, and sometimes you get tiny signals pointing in other directions. So the totality of the evidence here is overwhelmingly clear that aggressive lipid-lowering therapy is not associated with an increased risk of dementia, and is likely to be associated with a significant reduction in the risk of dementia, all-cause dementias, vascular dementias, and even Alzheimer's. So I don't see a big distinction here. If at all, I see them as aligned in what I'm trying to do. And so I do not see this as a factor. I think this is simply something that is brought up by individuals just trying to be anti-establishment. And I think I have seen a handful of patients who have developed some brain fog, etc. But that is not the same as dementia. That symptom happens, we stop the medication, the features go away. And it's important to point out that the appearance of those symptoms is not a diagnosis of dementia. So let's see here. I'm concerned about taking statins because of muscle weakness, but I've also discovered that I have an Lp(a) to factor into the equation. So there's kind of two questions here. One is around muscle aches, joint pains, or what is often called SAMs, or statin-associated muscle symptoms. So the literature here is very wide because of the degree of the nocebo effect. We know that anywhere from between 5% and sometimes up to 20+% of patients will get muscle aches and joint pains on a statin therapy. But if you actually blind the individuals to whether they're getting a statin or a placebo, the effect essentially goes away. And what you find is that people are way more likely to develop muscle symptoms when they take a medication that they believe is a statin therapy. And so we're just humans. We are all fallible to these particular situations. And what I say to individuals and patients of mine is that I can guarantee you will not have to deal with lifelong muscle aches and joint pains secondary to statin therapy. The reason is that if you develop those symptoms, we will simply stop the medication, and the symptoms go away and we switch you to something else. Let's see here. Is it advisable to take CoQ10 with statins? Generally, I think no. CoQ10 are actually rather expensive supplements. It was often used to reduce muscle aches secondary to statin therapy. I think given the other options that we have available to us now, I think using a supplement to offset a muscle symptom isn't necessary. We just have lots of other options that we can go to. So there's no need for anyone to use these to try and offset. And I even think the literature around this isn't great. Some meta-analysis will say there is some benefit, but I think the degree of nocebo effect here really distorts the actual findings. Okay, sorry, I never answered the question about Lp(a) or lipoprotein A. And so this is a person who has an elevated Lp(a). They're on a cholesterol-lowering medication and have a calcium score of 6 at the age of 32. So this is a really important point to take away. Lp(a) is a type of cholesterol particle present in about 10 to 20% of the population, associated with early coronary disease. It's genetically inherited. It's nothing to do with lifestyle. It does increase risk, but doesn't guarantee that you will get coronary disease. But if I hear the story of, say, dad had a heart attack at 50, his dad had a heart attack at 50, their kind of uncle had a heart attack at 50, this is what I'm thinking about. The key thing to point out here is that this individual is 32 years of age with a calcium score of 6. And 6 by general standards is a very, very low figure. I have patients with calcium scores in the multiple thousands. However, having a calcium score of 6 at age 32 years of age is way more than we would expect for an age-matched peer, and tells you that that person at a very young age has kicked off the development of advanced plaque at a very young age. So on a trajectory basis, they are way off course. In terms of whether the calcium score should be repeated, I generally don't think it's necessary to do so as long as you're very aggressively managing all of your risk factors, or you may repeat a CT coronary angiogram if the person develops chest pain as to whether they may need to go on and have an angiogram, a stent. Is it indicated to have a CT coronary angiogram that includes radiation and dye in an asymptomatic patient with hyperlipidemia? Now, so this comes down to a question of how much you want to know whether or not you have coronary artery disease. The answer is you do not have to have a cardiac CT, but it gives us the most information in terms of whether or not the risk factor that you're concerned about has translated into the disease that you're concerned about, i.e. atherosclerosis or plaque, how much you have, and what degree of risk you have over kind of the near term. In terms of the options of doing a cardiac CT, CT coronary angiography does involve radiation, some dye, and often the use of medications like a beta blocker, but you can get a CT calcium score that is a much, much smaller amount of radiation, akin to, say, 2 mammograms, and doesn't use any additional medications or contrast. And it will give you most of the information, but not all, specifically around non-calcified plaque. But it will get you most of the way there should you really want to understand the answer to that question. What should I be doing to manage high Lp(a) and FH? So this is a question about someone who has two genetic cholesterol disorders, a genetic cholesterol particle disorder, and then an excess cholesterol number. The bottom line is you should be seen by a specialist cardiologist. So this isn't just a surface level answer. You should be working directly with a cardiologist and managing all of your risk factors as aggressively as possible, in my view. Let me see here. Aspirin to reduce cardiovascular risk. Okay, so this is something that has very much changed in recent years. Historically, we used to give aspirin to everyone, and people would not even require a prescription for it. But what we've learned is that the bang for buck that you get with aspirin therapy isn't as great as we had thought, and secondly, the bleeding risk that comes with it is probably much higher than we had thought. So what we found is that the people who derive benefit from aspirin therapy are those at the highest risk, typically those post myocardial infarction or heart attack or post stenting, for example. In those who have high calcium scores, there is some evidence to support their use, but certainly in low risk individuals or calcium scores typically less than 100, we tend to avoid it because of the excess risk that the bleeding causes. So it is a risk-benefit analysis for each particular individual. A question of someone who's on cholesterol-lowering medications, and the question is how many eggs a week are safe to have? I think in general, this particular topic is wildly overblown. Most of the cholesterol that you consume does not actually make it into your bloodstream. The majority of the cholesterol that is in your bloodstream is produced natively within your liver. However, for some individuals who are eating very large amounts of eggs per day, they can see an increase in their cholesterol levels, but most people don't. The only way realistically to find out if that is an issue for you is trial and error. But eating moderate amounts of eggs over a weekly basis is typically not going to be an issue for most people. But if you want to find out, you need to do a pre and post assessment and change no other variables like going on a cholesterol-lowering medication. Let's see here. Lots of people asking questions with very detailed medical histories, which I really can't answer. Can you explain the relationship between cholesterol and plaque? Is plaque composed of cholesterol? So this is a very important distinction to make. Cholesterol is a risk factor for the development of plaque, or technically atherosclerosis. Just because you have high amounts of circulating cholesterol does not mean that you have coronary atherosclerosis. It certainly increases the risk of it, but fundamentally the distinction between the two of them is a cholesterol particle is circulating in your bloodstream. One of those particles, for example, crosses over the wall of your artery, becomes retained, the cholesterol is retained, and it sets off an inflammatory process. The residual buildup in the artery wall is the plaque. So there is a direct relationship between the two of them, but it's always important to point out that just because you have high cholesterol does not mean that you have advanced heart disease. Let's see here. No risk factors in a generally well individual, but one of the parents died at age 52 from a sudden heart attack. This is where I think you need to be assessing genetic cholesterol risks, and specifically Lp(a). We know that 10 to 20% of the population have an elevated Lp(a), and we know that only about 1% of the population globally have been tested. So we do a bad job at identifying this particular risk factor. That's the first place that I would look. The second thing you want to think about is, in these individuals, most people are asking not do I have a risk factor, what they're asking fundamentally is do I have disease and do I have high risk in the near term? The way that I typically go about answering that question is by way of doing a cardiac CT, because that answers really the question the person is trying to address. Yes, of course, we understand all of the risk profile, but it's all about actually understanding how that relates to disease and risk. Okay, let's see here. I watched a documentary a few years back on a reputable English TV channel, and one of the top cardiac consultants stated that, and I'm paraphrasing, eating butter and cheese and natural unprocessed fats and expected to die of heart disease is the same as eating spinach and peas and broccoli and expecting your skin to turn green. What do you think? I think that's pure gobbledygook as a line. This is no reflection on the person who is asking the question, but to me, anyone who uses who's describing themselves as a top consultant, that is always a red flag to me. But the question underpinning it all really is does saturated fat cause heart disease? The relationship here is very clear over very longer-term observational data studies that increased saturated fat is associated with higher rates of heart disease. However, the absolute majority of that risk is mediated through higher cholesterol. So the question you should really be asking is my diet built in such a way that saturated fat is causing excess high cholesterol, and is reducing saturated fat something I would be willing to do to reduce high cholesterol? That's something you can find out for yourself by basically changing around your diet and then reevaluating your blood tests. Some people reduce saturated fat and get a big reduction in their LDL cholesterol. Some people reduce saturated fat and get very minimal changes. What I would focus on more is what your LDL cholesterol is doing rather than your saturated fat. And we also know that people's ability to maintain very low fat diets over very long periods of time is somewhat difficult. So again, focus on the risk factor. I don't focus as much on the saturated fat question. Let me see here. Okay, yeah, so this is a really interesting question here that I think, so someone has a high, again, Lp(a), and an LDL of 5.1 millimoles, so that is very high, but a normal ApoB and a calcium score of 60. Is it the normal ApoB that helps keep the scaling is calcification, down? A couple of issues with this question. Number one, the ApoB of selectively not said, and it's 127. That is a very high ApoB. That is not a normal ApoB. So I think when we are using these more advanced tests, you need to be very clear about doing it with someone who can properly understand them. A calcium score of 60 means that that person already has advanced coronary heart disease. Now, if that person is 85 years of age, that's a very modest burden of plaque for that individual and a relatively low lifetime cardiovascular risk. But if that individual is, 45 years of age with a calcium score of 60, that's quite different. And so this person has a high LDL cholesterol and a high ApoB and a high Lp(a). Again, they should be working directly with a cardiologist or someone who's very skilled at managing cardiovascular risk. Let me see. Long question here. There's a very long technical question that someone's including very technical points around syntax scores and ischemia trial and FAME2. So this is a question that basically says, is there a benefit for stenting in asymptomatic obstructive coronary disease? So if you have, say, a 70% narrowing in one of your arteries, but no symptoms, should you have a stent? The study that they're referring to is the ischemia trial, which basically said there is no real difference in cardiovascular death or in the composite endpoint of major adverse cardiovascular events. But the FAME trial used a specific pressure analysis, and those who had an abnormal pressure analysis and who had stenting had better outcomes. But this is where the devil is in the detail, and you need to actually look at the specific trials. The thing that drove the difference in the FAME 2 trial was basically early revascularizations, so someone coming back in for stenting. Now, this is very quick to happen in someone who has known documented obstructive coronary disease, and they come with any variety of symptoms, and they'll very quickly often get stented based on our historical practices. So I don't think you can really use FAME 2 to advocate that stenting in stable coronary artery disease is something that really changes outcomes. I think the ischemia trial is a much more powerful driver of our medical information here. So what I would say is do you need stenting? For non-left main stem disease, I would generally say you don't, but it's an individual conversation with the patient and the clinician. Someone has a previous stent operation, so percutaneous stent. What can I do to avoid having a third one so the second one, so a third one in a few years' time, and how can I reduce calcification? So the calcification question we've already addressed. How do you reduce future ones? It's basically being as rigorous as possible across all of your risk factors, from lifestyle and making sure that everything is in check, from blood pressure, aggressive LDL lowering, ensuring that you don't have genetic cholesterol particle disorders like Lp(a) that we may have future therapies for in the coming years, and just pulling every lever of risk reduction as hard as you possibly can. Doesn't guarantee that you won't get a future stent, but it reduces the future risk, and working very closely with a very good cardiologist. Why does my sleeping heart rate rise so much, about 20 beats, even after a couple of glasses of wine? So I think the answer here is that your heart rate is not going up after the wine. It's just not able to go down at nighttime. So most individuals, when they go to sleep at nighttime, their heart rate will lower. But the problem is if you have drank alcohol, which on some levels is a stimulant, and also means that it interrupts your sleep architecture. So the person is getting light sleep rather than deep sleep. So they generally don't get the same reduction in their heart rate, and they don't get the same restorative sleep, and ultimately don't feel as refreshed in the morning. So that's typically what it is. Sometimes higher heart rates at nighttime can be a reflection of obstructive sleep apnea. So that's an important consideration as well. So we've answered quite a few of the questions. I hope that is useful. This is a trial that we're doing. If you find it useful, please let us know. If this is something that is valuable, we can do them again in the future. But as always, I hope you keep the odds on your side, and I hope you keep tuning in for lots of information in the future. Okay? Talk soon. Bye.